Hi everyone, welcome back to our journal club. And somebody, I think, asked which number journal club this is. We're on our 14th article tonight. So we've gotten through, like, if you're following along and trying to do your MOC, you would be almost halfway done because you have to do 30 articles to get your MOC. So right now we are just waiting for Dr. Kathleen Gould to join us. If you guys recall, she was with us previously and she's joining us again. Just waiting for her to join the video. I see her watching. So, okay. And I think she should be getting on any second. Great, let's get started. I think I'm approving. It says it's adding her. How's everyone doing? Say hi if you would like, for anybody watching. I never know, like.
Okay.
Oh. Oh, hi, Kathy. You know what? It looks like you might be upside down.
Yeah. Oh. My earphones sit on the bottom.
Oh. Okay.
Okay. Let me see if I locked it. Hi, everybody. Sorry for the delay.
Oh no, I just got on, so.
Let me see if this adjusts itself. No. Okay. All right. So, I'm gonna put the iPad on the corner of the table so that the earbuds can hang over the edge.
Okay.
And I think we're mostly okay. Let me move
back
a little bit. Hi, everybody.
Hi. We are live, guys, and 1 second, I'm just pulling up. Okay, I don't have my phone calls turned off. Somebody just called me. Hi guys, for anybody watching. Dr. Gould and I have never done this before. So both of us are just in top form tonight. No, actually, this is Dr. Gould's second time, and I'm so excited that she's back. And I am not going to read through her entire bio, but just briefly, she's with Wellspring Health Associates, which is a private practice here in Chicago, Illinois. And welcome back.
Thank you. And actually, patients with borderline personality disorder are near and dear to my heart.
That's right.
Yeah. And then people always look at me funny. I'd also like to just take a brief moment and acknowledge a wonderful mentor and teacher in the area of borderline personality disorder, John Gunderson, who died on January 11th.
Oh, I didn't know that.
Well, a long illness, and surrounded at home by his family. So, but he,
he was amazing.
He was amazing. And a long time ago, patients with borderline personality disorder were frequently being diagnosed with schizophrenia. And a lot of the treatments, either for schizophrenia, and at that time they were doing psychodynamic psychotherapy for schizophrenia too. So the standard treatments at the time made things worse.
Yeah.
And so John Gunderson was really at the forefront of defining this as a separate diagnosis, and also at pioneering with what kinds of treatments help and don't help. Marcia Linehan, who's the author of this study. So I just had to really acknowledge John.
Yeah, of
course. Marcia Linehan is gave an interview to the New York Times some years back that would lead some of us to conclude that she definitely had borderline personality disorder herself.
Mm-hmm.
And like so many of these patients, is extremely intelligent, extremely thoughtful. She started studying Zen Buddhism, and her Zen Buddhist teacher helped her. And she also was trained as a psychologist, as a behaviorist, and started looking at what would help patients with borderline personality disorder from a behavioral point of view, as opposed to a general psychiatric point of view, which was John Gunderson's area. And dialectical behavioral therapy is evidence-based, and as she points out in the article, the most recent Cochrane review concluded that DBT is the only treatment with sufficient replication to be considered evidence-based for BPD, although some of us would argue that. Apparently, there was a significant amount of arm wrestling back in the day between Marcia and Linehan and Otto Kernberg, because Otto Kernberg said a psychodynamic approach works, and Marcia said, "I've got data," and so prove it. And so that really spurred Otto Kernberg's work in standardizing, validating, and researching psychodynamic treatment. So that's really cool. And I didn't know that there had been like Star Wars back in the day. But
yeah.
But Marcia Linehan has been rigorous in her study of what helps, what doesn't help, and that's what led to this article. Because the research model, the treatment model that has been studied in the past and shown to be helpful for suicide risk in patients with borderline personality disorder is standard DBT. Yeah. Standard DBT consists of weekly meetings, or in some cases more frequent meetings, with an individual DBT therapist who is available for telephone coaching on what skills to use in crisis. And the patient has a 2.5-hour skills group meeting each week. And there is a consultation team, which is group supervision and group consultation for the team working with borderline patients, because they're difficult to work with and the team works better. So in this study, just in the real world, it's team intensive, skills intensive, labor intensive to deliver a fully compliant model. Right. And a lot of people were offering skills groups without the other components of treatment. They're offering individual psychotherapy guided by DBT, but without skills groups, and some people were doing the fully compliant model. So, and again, I really admire Marcia Linehan because she is so rigorous in her thinking, and also because she follows her own acceptance and non-willfulness. If people are doing it, am I going to race around the country telling them they're doing it wrong and they're not following the model? No. I'm going to study and see what actually works. So in this study, they tried to separate which of the components of DBT would be most helpful, with some interesting results. So they separated into a third of patients in a standard DBT model, a third of patients having individual DBT-informed therapy only, and a third of patients having skills groups only. This was a 3-arm, single-blind, randomized trial. So that means that there's 3 treatment arms, and the raters were the only ones that knew or that did not know which treatment condition the participants had been assigned to. Obviously, you couldn't hide it from the patients or the treaters. You can't give a placebo. So assessments were conducted before treatment and quarterly during the first year of treatment, and then 1 year of follow-up. And these were independent consultants, who none of whom were treating any of the patients in the group. They used the suicide attempt self-injury interview, the suicidal behaviors questionnaire, the reasons for living inventory, and the treatment history interview, as well as the Hamilton rating scale for depression and rating scale for anxiety. And everybody had these attempt assessments quarterly. For the first year, participants received the treatment that they'd been assigned to. And the second year was a follow-up year, although she does not say whether individual treatment continued, or any kind of, whether participants continued in any kind of treatment in the follow-up year. They weren't in treatment under the auspices of the study. Requirements for entry to the study were women aged 18 to 60 years who met criteria for BPD, and had at least 2 suicide attempts or non-suicidal self-injury episodes in the past 5 years, at least 1 suicide attempt or non-suicidal act in the 8-week period before entering the study, and at least 1 suicide attempt in the last year. They allowed 6 women into the study with a little bit of relaxation of, okay, you can, if you didn't attempt suicide in the past 8 weeks, but you had self-injury, okay, you can come into our study, which is, if you think about that this is part of the treatment outcome, reducing or modifying the severity criteria for a small portion of the participants might have, shaded outcomes a little bit. So apparently there were recruitment difficulties. The point of that, though, is that there was similar acuity, because a suicide attempt or non-suicidal self-injury in the 8 weeks before means that the borderline personality condition is active. Okay, the therapists were similar in clinical experience and in training. And I'm not going to go through the exact differences in what constitutes individual therapy versus a skills group, unless there's questions at the end, because I don't think the outcomes were interesting, and I'm not sure it's what Marcia Linehan would have wanted to see exactly, because more treatments dropped out of the individual therapy assigned group. And that makes sense to me, because I think having a lot of, being part of a skills group and having an individual therapist gives a lot of support to acute patients, whereas it would be harder to engage people in treatment with once a week psychotherapy. So I think the conditions were not as, the patients weren't held and engaged as much by having some place to go and having that structure of the skills group. And also patients dropped out of treatment faster in the individual therapy group. So participants in standard DBT had more sessions overall because they were assigned to skills groups and individual groups. So you can get that there are some differences in the amount of treatment that patients got. but they tried within the confines of separating out the factors to make it relatively the same. The people that were in skills group only had case managers that they met with, not for therapy, but as needed. So they made an effort to make it even, but it wasn't possible to make an equal amount of contact. Those of you who were with us when I did it last time, I was shuffling my papers. Today I stapled them, so that won't happen. So there was no significant difference between groups in the occurrence of any suicide attempt, the mean number of suicide attempts among those who did attempt, the occurrence of any non-suicidal self-injury, the level of medical risk for suicide attempts, and also for non-suicidal self-injury, and level of suicidal ideation and improvement in reasons for living. All of the bad things got better, and the good thing, reasons for living, improved in the correct direction. You get what I'm saying? So it was interesting to see that overall patients got better and there was no significant difference between the groups. However, the only difference was the frequency of non-suicidal self-injurious acts did not improve as much in the individual therapy arm of the study. And I guess I should mention that the individual therapy arm of the study was the same in that patients were asked to use DBT skills that they already knew. That's part of the interaction in individual DBT therapy, is that you coach the patients on, okay, well, you know, to do this skill or that skill, and did you do it, and what made that hard? But they couldn't teach any new skills. Okay. So in the absence of that, the non-suicidal self-injury did not improve as much, and because you couldn't learn any new skills if there was a gap. There was no difference significantly in the treatment in the number of ED visits or hospital admissions for any psychiatric reason in the treatment year, which is year 1. But during the follow-up year, fewer participants in the standard DBT group than in the individual therapy group visited an ED for any psychiatric reason, or were admitted to a psychiatric hospital for any psychiatric reason. Remember, a lot of these patients had co-occurring diagnoses. So admissions and ED visits for general psychiatric reasons were reduced, but not reduced as much in the DBTI group, the individual treatment group. And there was no difference between groups in the rate of ED visits or hospital admissions for suicidality alone during the treatment or the follow-up year. Depression improved less in the DBTI group than in standard DBT, which is interesting. And we'll talk through a couple of reasons for that. And I think at the end of the study, actually, patients were less depressed overall in the standard DBT group. Okay, see, I am shuffling papers again. Anxiety did significantly improve in the standard DBT and in the skills group, but not in the DBT individual treatment group. So it's interesting that standard DBT and skills DBT seem to be good for depression and anxiety, and there is some component of the combined treatment that is more effective than working with an individual therapist, even informed by the DBT model. One thing that I want to interject here is that for major depressive disorder, and I don't know what the outcomes are for anxiety disorders, but for major depressive disorder that's co-occurrent with borderline personality disorder, the depression does not tend to remit unless the borderline personality disorder is treated and improves. So that would be a reason that we saw, an improvement in depression over the course of this study. And I would think that since DBT is good for BPD, the outcome measures might not have, the treatment conditions might not have mattered so much. And it's interesting to see that the standard DBT actually did very well and the individual therapy did not. So they don't discuss medication use. Medication use in this study was provided under and as needed, for good, prescribing, whatever good prescribing seemed indicated by a member of the team. They didn't limit it. Or one thing that they did was they excluded patients who had seizure disorder, who had to be on anti-seizures. So given that anti-seizure medication has frequently been used for symptomatic BPD, probably they were trying to exclude patients who had to use these medications that might blind the outcome. So Dr. Linehan would not want us to conclude that the skills groups are equivalent to the standard DBT treatment. She doesn't think that this study sufficiently established that. There was a trend towards that. But it did seem that the skills group or the standard DBT showed trends towards improved outcomes, even when there was non-significant outcome for the over the individual therapy group. So it's the skills plus an ongoing, like learning new skills and working ongoingly with an individual therapist to apply the skills that you're learning to you and learning new skills, which are the components of the robust treatment. And the trend is towards superiority of those two elements over the individual treatment on its own. There's a couple of highlights if we still, we're running out of time a little bit. I'd really like to just ask people to look at a couple of things. Look at the baseline demographic and diagnostic tables. A lot of these patients, like more than half of the patients in each arm had some college or technical school. And at the same time, the average income of a college-educated person tends to be at the median income of, the United States. College graduates this year make about $50,000 average, and the median income in the U.S. is about $50,000. These patients A significant percentage were making less than 15,000, although a significant percentage had been educated at the college level. Most of the patients were less than $30,000, and I know this was some time ago, but there's not been a $20,000 gain. So in between 2008 and 2018 in the median income. And the majority of these patients were single. So what I want to point out is that there's this population of patients, life is not kind to. They're not having vocational or relational success, and you can see that in the baseline demographics. And what I would like to see is changes in some of these factors after treatment. I'd also like everybody to look up the Linehan risk assessment, the LRAMP for Linehan risk assessment and management protocol, which is extremely good way of working with chronically suicidal patients and considering the risk in a patient who's chronically suicidal that might have acute bumps. And it's well worth looking up. And with that, I will stop talking. Thank you.
Well, yeah, no, thanks. That was great. And thanks for the historical context at the beginning,
I
too.
always like to gossip.
Yeah. No, it's helpful to know that. So, if nobody has any questions, I think we can wrap up. Like I said, this is our 14th journal club. We're going for 40. I know that there's, so we're getting close to the halfway mark. If anybody has any questions, feel free to post them later and we'll try to get to them. And otherwise, just keep an eye out for the schedule. Next week, we have an article on antisocial personality disorder and one on intermittent explosive disorder. So we're kind of making our way through. There does seem to be some sort of order to these topics. So
the DSM, yes.
Yeah, basically. Yeah. All right. Well, thank you, Dr. Gould, for
thank you, Dr. Gerges.
Your time. All right. And everybody have a good night.
Thanks. Bye-bye.
Take care. Bye.